Welcome to Adapting Class. This is your cardiology crash course. In the next few minutes, I need you to walk with me through the cardiac unit from chest pain, heart failure, shock, tamponade, cardiac arrhythmia, post-op emergencies. We're going to see multiple patients. By the end of the walkthrough, you know everything the NCLEX is going to ask you about cardiology. Grab your stethoscope and let's go. First room, room 1, 50 years old, male. What is his complaint? He's very sweaty. And what is he saying? He's anxious about everything and he's clutching his chest. He said he's hurting. How long? Last 10 minutes. That's when he was admitted to the unit. And he feel like pressure in the chest. It won't go away. Won't go away at all. What do you think is wrong with this patient? He tell you he never see a doctor. So never see any doctor. And this is what happened to him. What do you think is going on with this patient? This patient, what should be your priority? This is the way the NCLEX will present to you. You look at his heart rate is 110 and his blood pressure is very high, 150/90. What is wrong with this patient? Your room 1, you can see he has classic symptoms, what? Cardiac event. The main thing you have to know is this unstable angina versus what? Stable angina. That's the thing that you have to pay attention to. So unstable angina versus stable one. And is this ST elevation MI versus what? Non-ST elevation MI. So this is a cardiac event. What is your next step? This is what they usually test. Don't tell me, Mona, because if you do that, that's wrong. This is an emergency. So for the NCLEX, assess the patient. So assessment and get the EKG. EKG will tell you if this is what? ST elevation MI or non-ST elevation MI. The patient is at rest. He's not moving. He's not exerting himself. And the pain is not going away. So at minimum, this is unstable angina. And so this is the difference you can tell between stable and unstable. Unstable, you cannot predict it. Stable one, you can predict it. What is your management? First thing, assessment, the EKG, followed by what? Because the assessment, you got to check it. Airway, breathing, circulation. Then after that, you do your MANA, right? You do your MANA, you have to give it to him. You do morphine, oxygen, nitro, and aspirin. Pay attention. Always assess the patient first in this situation. Don't give him morphine, don't give him oxygen or nitro or aspirin until you figure out what is going on. So assessment and EKG at the same time, simultaneously, before you proceed. If they put virus there, that's the first thing you check. This is your first patient. This is your room. You've taken care of this patient with a cardiac problem. Are you ready? After you finish, you high-five each other and they call you into the next room. The next room, what is going on? There's 2 patients there in room 2. And what is the patient complaining about? When you listen to him, he has crackles in the lungs. He has shortness of breath. And then what is he telling you? He said, I'm gaining weight. So weight gain. And look, I can't breathe. He said, I can't breathe at all. And I can't lay flat. What is going on? I can't lay flat. Laying flat is a problem, flat. So it's a problem. And then when I am asleep, I usually wake up in the middle of the night. This is orthopnea, right? This is problem. And then you look at the other side, it's another patient is neighbor in the same room. The other guy, mostly his ankles are big, ankle edema. And you look at his neck, he has JVD, jugular vein distension. And you can feel like you can palpate the liver, right? Liver is big, hepatomegaly. You can palpate his spleen. The spleen is big, splenomegaly. What is going on with them? And you say, and you look at his abdomen is distended. He has what? Ascites. And when you came back to the other guy, his blood pressure is low. This guy, blood pressure is low. And the last time in P, he has urine output is very low. So low urine output. What do you think is going on with them? This guy has a left-sided heart failure. And this guy has a right-sided heart failure. So you have two different heart failure in the same room. And these are signs and symptoms the NCLEX will ask you. This is the difference you can tell between them in the straightforward, simple way. What should be your management then? What do you anticipate? A, we're going to do daily weight for all of them, right? But that should not be your priority. Is they are long, right? So they will need diuretic in order to get rid of all the fluid that is causing the problem. We're going to check their electrolyte, right? BMP. That's key. What do you expect? Their BMP will be checked daily, and then what lab work will be elevated? BNP. And what level do you want it to be? Greater than 100. It's just a definition of what? CHF. What should be your priority? Just because you have CHF doesn't mean higher BNP is a priority. What are you looking for on the NCLEX nursing school? What are you looking for? Signs of pulmonary edema, where the patient is drowning. And what word are you looking for? Pink fluid sputum. This indicates pulmonary edema. This is your priority. Or if they gain weight too fast, like 3 pounds in 2 days, right? That's bad. Or 5 pounds in 7 days, that's really bad. These are signs of symptoms of CHF exacerbation. And therefore, pay attention to that. That's your room 2. And you've taken care of this patient. You've taken care of them well. And you high-five each other. You're about to leave. And they call you to the next room. You are in the third room, room 3. What do you see? In room 3, there was emergency. The patient is what? Coughing. He's coughing blood. He's coughing what? Pink, fruity sputum, like we talk about. And he's having shortness of breath. He's gasping for air. What do you think is going on? Right? What will be your initial care? If you see this as a question, a patient coughing blood, pink, frothy sputum, shortness of breath, and gasping for air, I just told you this patient has what? Pulmonary edema. And therefore, what do you want to do? It does not want oxygen right away. The first thing is what? High Fallot position. That will allow the patient to breathe. Then you can put oxygen on as oxygen mask, right? And then they will need some fluid to be removed from their body. And that is when they need diuretic. This is furosemide. And then sometimes you may have to open their lung and the vessels. They may need some nitro for afterload reduction. That's your management of what? Pulmonary edema. There is a mnemonic. If you see it, pulmonary edema is flow, MN, which is what? Fallot position, furosemide, which is the lasers, oxygen, right? And then sometimes they give them morphine and nitro. This is your cardiac crash course. You've done well. You are in room 3. You've managed them. Like I said, I'm trying to make these NCLEX relatable. These cardiology is big, but there's little things you need to hold on to. If you hold on to, you know cardiology, and you're on your way passing. You can use this little information I'm giving you. If you don't know anything at all, these are little things you know. When you take a question, you say, oh, I remember pulmonary edema. These are the things I need. In room 4, you're tired. You think you won the battle. But this patient is pale, is cold, and is clammy. These are buzzwords. I did a video about how the NCLEX is now testing. They're using buzzwords. These 3 things should tell you what is wrong with this patient. A pale patient who is cold and clammy, his MAP is what? 55. That's mean arterial pressure. This is hypotension. and his heart rate is what? 110. What is wrong with this patient? What do you think is going on? Think about it. A MAPO 55 means blood flow is decreased. This is hypoperfusion. And therefore, there is less blood going to the extremities. And then you listen to them, they sound coarse, right? They have crackles, right? In their lung, right? They have shortness of breath in addition. These are signs and symptoms associated with what? This patient is in cardiogenic shock. This is classic cardiogenic shock symptoms because of cold, cramming, hypotension, and signs of what? CHF. This patient is cardiogenic shock. What would you do? What would be your priority? What is your management? Shock is hypoperfusion. Improve the perfusion. How? It's cardiac. It's cardiogenic. Don't give them fluid. Okay? Never give them fluid. Improve their cardiac function. And how do you improve their cardiac function? Fix the broken heart, which is what? Push the heart. Push the heart. So this patient, we're going to check their mental status. We're going to give them ionotrope, something that is going to push the heart. If you see a fluid as an answer, it's okay, but what? Cautious fluid. Answer choice has to be cautiously, not giving them too much fluid. Otherwise, they're going to go into shock. You overwhelm them. This is the key, right? It's very, very important. So remember, cardiogenic shock is a pump failure. And therefore, I need to pump you up. That's the major thing. So they need ionotrope, and then you can monitor them. You are in room 4. You've taken care of this room 4. You've done really well. What do you think you should do? You got to go home, change shift. But guess what? Before you're about to change shift, there's a patient who just had what? Surgery. It's post room 5. You are in room 5. It's post cardiac surgery. You are about to go give a report, right? All of a sudden, it's hypotensive. And what is going on? He has JVD. Wow, I'm in trouble. He has muffled heart sound. And you said, what? I've seen this before. Cardiac surgery? What does people who have cardiac surgery do? They may have chest tube, but chest tube doesn't do like that. Why is the patient hypotensive, JVD, and muffled heart sound? You said, oh, you look into your encyclopedia, you said, I know these 3 things. It's called what? Beck's triad. Therefore, what do you think is the patient suffering from? You went further and you get more information. When you check their blood pressure, the systolic blood pressure, it dropped when they take inspiration. You say, oh, pulsus paradoxical, right? Point or 10 to 15 when they take a breath. You say, oh, that's a problem. And you check the blood pressure, they have like what? Narrow pulse pressure. Narrow pulse pressure. Say, oh, that is a problem because the blood pressure are too close to each other. Blood pressure is 150 over 140. What do you think is going on with this patient? This patient is in trouble. He's having what? Cardiac tamponade. You have a room of a patient who has cardiac tamponade. What do you think is going on? They're bleeding into the chest, into the pericardial cavity. And therefore, how would you manage these things? You have to get rid of the fluid. Therefore, they will need pericardial centesis. Centesis means removal of fluid. This is the way you should be going through the process when you learning about NCLEX, right? Try to make it relatable and straightforward as much as possible. I need to go in and remove the fluid. I need to protect this patient airway, and I need to monitor them. But this is the key symptoms you may see in a patient with what? Cardiac tamponade. That is very key. A post-cardiac surgery patient, muffled heart sound, pulsus paradoxical, and narrow pulse pressure. Those are all key things you should worry about. And those are signs or symptoms of what? Cardiac tamponade. How are you doing so far? You've handled really hard questions, 5 cardiac problem the NCLEX is going to ask you. So these are your first 5 patients you manage. You've done well. You should give yourself a pat. This is our cardiac crash course, trying to make all these difficult topics easy as much as possible to help you pass your NCLEX. That is the purpose of this short, relatable video. And then you went into room 6. And what did the monitor show? Patient has a heart rate of 150. Wow. And he has irregular pulse. Which of these rhythms belong to that patient? So, oh, I look at it and I said, this is regular. This has nothing on it. Therefore, it has to be this. This is atrial fibrillation. You have RR interval are not the same. This is how you can recognize Afib. And then you ask yourself, how am I going to manage this patient? The first thing you come to your mind, Afib with the heart rate of 150. What is your first thing? And then you think about it, you say, I'm worried if this patient is stable versus unstable. If the patient is stable, what would you do? I need to do rate control. And what kind of rate control? Medication, anything that can lower the heart rate, anything at all. It does not matter whether it's the beta blocker, calcium channel blocker, amiodarone, you can give it to this patient to lower their heart rate. But if the patient is unstable, what does that mean? Shortness of breath, the blood pressure is low, it's diaphoretic. Hey, I'm in trouble. What would I do? Would I give them medication? No. What do you need to do? Cardioversion. Synchronizing cardioversion as much as possible. And when you're doing synchronizing cardioversion, what is your number one thing? Put the sync mode on. Otherwise, you're going to kill them. That's all. You see how you manage cardiac rhythm? This is the way you should connect them. This is all. You don't need to worry yourself too much. Break it down like that. And that's how you manage them. Put the sync mode on and then provide the synchronized cardioversion if they are unstable. But if they're stable, we're going to give them medication to lower the heart rate. That's all. Now, you look at the next, the neighbor in the same room, room 6, you say, I look at the cardiac monitor and I see this. I said, what is this? It's not atrial problem. This is all ventricular. It's not flat. What is this? And you see, it's uniform. I know that this is a ventricular tachycardia. What would I do first? First thing I would do, I'm going to check pulse. And when you check the pulse, patient has pulse. You say, oh, I'm good. If there is a pulse, then what am I going to do? Medication to slow down the heart rate. No matter, you can pick anything, beta blocker, calcium channel blocker, everything. It does not matter. A, I check, patient has no pulse. What would you do then if he has no pulse? Is what we call pulseless VTach. And you know from your cardiology lecture that you're watching right now and say, pulseless VTach is the same thing as VFib. And if it's a VFib, what do I do? Immediate defibrillation. So this patient is going to get VFib. That's the thing. Immediate defibrillation, not cardioversion, if they have no pulse. And before you left the room, the third one, you are not hearing anything. He's in the room, 3 patients in the room, but you are not hearing anything. You look at the cardiac monitor and you see a flat line. You say, oh, we are in trouble. The most unstable patient in that room is almost dead. What would you do? No shock, no shock, no shock, no shock. Once again, no shock and no shock. Because what? This patient need immediate CPR. That's what they need. Immediate CPR. Never shock this patient. How wonderful have you done? You've saved 3 patients who are in trouble and you have managed them. How do you do? This is how you manage cardiac problems. EKG, if you have problem, check adapted class videos like that. But these are the little things you will see. That's what they're going to ask you. The most salient things that shows up on test is the little clinical implication. You went to room 7, you said, I'm tired. This keep on coming. And then the first patient you saw, the monitor, this is what it shows. He said, it looked like sinus rhythm. But what is the problem? It looked like sinus rhythm, but what is the problem? I saw these like a saw. I can't differentiate between the atrium or the T wave. This is what we call Aflutter. This identification of EKG. How do you manage them? You manage them like Afib. Check and make sure if they're unstable. If they're stable, then you give them medication. If they're unstable, cardioversion. But when you look down, you say, this one is different. It's fast. It's uniform. I can't tell the difference between the P and the T wave. They buried. It's both atrial and ventricular are normal, but look at the atrium. You can't see the P wave. This is SVT. And how do you manage them? It depends on the condition. If the patient is unstable, yeah, you go to cardioversion. But if they're stable, let them take Valsalva. If it's a kid, put ice in their face. And then what do you do? Adenosine. How do you give adenosine? Fast and fast. That's what I call it. Fast and fast. And use a vein close to the heart. You inject it, you infuse it, and you push it, flush it with 20 cc of saline. And this will stop the heart and you jump it back. But before you leave, you say, oh, this one, it looked like he's in trouble. There's no atrium, and it's all ventricular rhythm. It's all over the place. What is going on with this patient? We have a VFib. And if we have a VFib, what do? We have to do what? Defibrillation, immediate defibrillation as soon as possible. And this is the way the NCLEX will ask you. In real life, this patient will have CPR followed by immediate defibrillation. For your test, just pick immediate defibrillation so that you don't confuse yourself. You see, this is the way you should think about EKG. I'm giving you these little bit by little information to tell you that this is what it is. You know more than you think. You've taken care of what? 7 patients, 7 hard cardiology patients. Now you walk to your room 8, you feel like now you're on top of the world. What do you see? 2 patients in the same room. We are in room 8. And the room 8 is interesting. What is so interesting about them? On the left side, the patient is what? He said he get a parcel, a gift from Jane. Wow. I get a gift from Jane. And what did Jane say? Well, you have a fever. You have rod spots. Really? I have Oslo nodes. And what do? I have a heart murmur too. And then what is the problem? Janeway lesions in my palm. And I'm anemic. And then on my near bed, there's hemorrhages. E, I just left it behind. And I said, what is going on? I don't know what is E. I have fever, rod spot, Oslo node, murmur, Janeway lesion, anemia. Hey, that's bad problem. The next neighbor, what is his problem? Well, he mostly is complaining about chest pain that is relieved by leaning forward. He said, oh, I think I know what is it. And when you listen to them, you hear a friction roll, some clicking sound. And he also has some fever. And he told you he does not know what happened. What do you think is going on? And when you get the EKG, you see ST elevation in every field. I can tell you, number one, this is endocarditis. This patient has endocarditis. That's the difference between them. And this patient has pericarditis. That's the difference. How do you manage them? Endocarditis, mostly antibiotic, long-term antibiotic. You got to draw blood culture, then you give them long-term antibiotic. They may need prophylaxis for antibiotic in case they have dental procedure so that they don't get into trouble. What is your priority? The problem is their heart has bacteria that is being showered to every organ. And therefore, in the process, you have hemorrhages, you have bacteria in their fingers, in their palm, in their eyes, which is the rotor spot, right? Genway lesion in their palm. These are all portion of emboli. It can go to places that is dangerous. Number one, your brain. Number two, your leg. And if you go to your abdomen, you get ischemia. So you're watching for pulmonary emboli, stroke, ischemia. Those are your priority. But for this, they are not your priority. That's endocarditis. And then the pericarditis, what is the problem? Well, this is no chest heart attack, right? It's just friction rub and inflammation of the pericardium. Therefore, how do you treat it? Endomedicine. Give them NSAID, 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 NSAID. And then you monitor for what? What should be your priority? Watch for this. Priority. Priority function for pericarditis is cardiac tamponade. Therefore, if you have pericarditis with the friction rub, don't worry about it. Pericarditis with clicking sound, don't worry about it. Pericarditis with ST elevation in all fields, don't worry about it. But if you have pericarditis with hypotension, that's cardiac tamponade. Pericarditis with what? JVD, that's what? Tamponade. Pericarditis with what? Muffled heart sound, that's what? Cardiac tamponade. So you connect all the signs and symptoms with pericarditis. 8 rooms. How wonderful you manage these cardiology patients. And before you are about to sign up, you've not done finishing your rounds, you went to room 9 to go check on your patient who just had surgery. It's post-cardiac surgery also. And he has chest tube. What do you want to do? Well, you got to know the component of each chest tube. Now, a chest tube has 3 components. You have to know what function, the function of each component. And so what are you looking for? You went to the room and you said, is the chest tube output increase or is the chest tube output decrease? If it's increase or decrease, condition may change for after you have cardiac surgery. What do you think? This will be the patient. The patient is connected to what? This is your collecting chamber. This is collection. And this is connected to a suction. So this is a suction chamber. This is the air leak chamber and water seal. So I put air here. Here, what you see is just fluid coming from the patient. Here, what you see is the suction coming in, bubbling. Therefore, I expect some bubbling in the suction chamber, no bubbling in the collecting chamber, or I will see it's a fluid. Then you look at it, airway, water seal chamber, air seal, water seal chamber. You say, what do I see? I'm going to see what? Nothing, no bubbling. All you see is tidally. The fluid go up and down. If you see bubbling, what should you see? Just intermittent, not continuous bubbling. That's all you need to know about chest tube. Now, if you had cardiac surgery, what is my priority? I need to make sure the chest tube is not clogged or it's not overflowing. If the output is high, you're bleeding here. If the output is low, it's clogged, and you may have what? Cardiac tamponade. So the nurse supposed to watch for this. And when she went, everything was perfect. This was the room that she take a deep breath and say, oh, I've done a good job. Nothing happened in this room. This room is not bad. It's okay. And then she went for social round. That's room 10. And there is what? 5 patients there. One of them is in digoxin. What should he tell the patient? Patient is taking a beta blocker. What would she tell the patient? Patient is taking ACE inhibitor. What do you tell the patient? Patient is taking nitrate. What do you take the patient? Tell the patient. Patient is on furosemide, diuretic. What do you tell the patient? This is cardiac pharmacology. Straightforward, right? And then you see how I'm going to approach it. This is what you should do. What are you going to tell the patient with the digoxin? Well, draw my caricature like that. And you say, A, you're going to have a neural problem. If you have confusion, we have a problem. That's toxicity. If you have vision change, yellow vision change, that's priority. If you have GI symptoms, A, nausea, vomiting, that's priority. If you, in order to avoid having cardiac problem, you should check your apical pulse 1 full minute before you take it. And if you're an adult, because you're an adult, if your heart rate less than 60, hold it. That's all. But if it's a child, 70. And if it's a neonate, 90. And then you got to check his kidney function. These are the things you tell them. The beta blocker patient, you got to check his heart rate before you give it to them. You also tell them he's going to have orthostatic hypotension. All those things you have to tell. How about somebody taking a HESI inhibitor? Lensinipro. What is the major problem? Is A, angioedema. Tell them neck swelling, lip swelling, we have a problem. Cough. If you have nagging cough, it's not going away, let me know. We may change it to ARB. Electrolyte, your potassium is going to go up. Avoid anything that has too much potassium. And teratogen, well, if you're pregnant, you can't take it, you got to stop it. ACE inhibitor, NCLEX favorite. And if you take nitrate, sublingual, you cannot take sildenafil. No Viagra. Stay away from it. Diuretic, furosemide, is going to become hypotensive, orthostatic, get up slowly. But number one is your potassium is going to go low. So you got to make sure you replace your potassium. Eat some banana. This is a room that everything was uneventful. It was not bad. And the nurse was so happy. And then she said, well, she feel like she's so strong. She started thinking about rapid fire. She said, okay, she went and sit in the nursing station. He said, now she's in the nursing station. He said, I've seen 10 patients. Let me review all the things that I've done, the most important things that I've done. So if the patient has chest pain, what should I do? A, first action, assess them. Assessment first. Then I get an EKG. Then I do my mona. Okay, reinforce. That's recap of what we talk about. If the patient has pulmonary edema, what do? I have Fallot position as much as possible. Then I give them oxygen. If patient has Afib and his heart rate is what? 150. Well, I got to make sure that the patient is stable, does not have signs and symptoms of instability. If he does, synchronizing cardioversion. If not, I'm going to do what? Give them medication. If I see a patient who had cabbage, post-cabbage, and they are hypotensive, I should worry that they may have what? Tamponade, right? Cardiac tamponade. I need to check the chest tube and make sure the chest tube is not blocked. If it's blocked, then they have cardiac tamponade. If the chest tube is overflow, it means they may be bleeding too. So those are the two things you have to. And if you are in shock, I need to give you fluid. The nurse said, cool, adult cardiology, I've killed it. 10 rooms, I've conquered it. There's some had problem, there's some it was okay. But let me go to the pit ward and see what is going on. So she went to the pit ward and said, What do I see? I see some young kid. When he cries, it's blue. When you feeding him, it's also blue. And when that happens, you go into knee to chest position. What is going on with that patient? I look at his fingers, he has clapping fingers. And whenever you go on it turn blue, the nurse keep the patient in knee to chest position. And then we give them oxygen. Then we give them morphine. We check the vitals. Hey, what is going on with this patient? And then you say, oh, this is the problem. The kid is probably having what? Why is the kid going into the knee to chest position? It's because I remember there's something where there's a defect here, ventricular septal VSD, and there's a blockage of blood going to the heart, going to the lung. And these causes blood to pull in the right ventricle. And the right ventricle get bigger, it crosses the ventricle, and then the aorta push it out. These are all right to left shunt. So you have what? Pulmonary stenosis, right ventricular hypertrophy, ventricular septal defect, and overriding aorta, leading to what? Right to left shunt. And therefore, the baby is blue. And when he's blue, we got to stop the shunt. That's why we keep them in the knee to chest position. Tetralogy of Foley. Tetralogy of Foley. The next day, I remember that. We did it. Tetralogy of Foley. And that is how you learned it. This is where she remembered and said, oh, I conquered this topic. Then she went to the next neighbor and she said, oh, I listened to the kid. It's no blue at all. But when he's eating or crying, it's become diaphoretic, no blue. Eating or feeding will become what? Diaphoretic. And I listen, there's machine-like mama. There. I listen, there's a machine-like mama. Oh. And when I listen, there's a machine-like mama. I said, oh, what is that? The patient has bounding pulses. Hey, this is different. And he has wide pulse pressure due to that. What do you think? And the doctor ordered endomethacin so that we can close that is that wrong with this patient. The next guy, the nurse couldn't figure out, but she knows that this is a left to right shunt. So the baby is not blue, right? But they have a very loud, harsh murmur. It's not machine-like. This is VSD or ASD. They are risks of infection. So they're making sure they have masks and everything going. And then she said, I'm learning a lot. Then went to the next kid. This is a kid. The striking thing about this kid is when you check their blood pressure in their arm, this is way high. So high blood pressure on the upper extremity. When you check the blood pressure on the legs, it's very low. When you check the pulses too, very low. And when you check it in the arm, it's bounding pulses. So, oh, this is weird. This is what we call coarctation of the aorta. Coarctation of the aorta. These are buzzwords. I want you to remember them. When you give you a question, this is what they're going to say. They're not going to trick you. They're going to give you these buzzwords. Cardiology crash course, dealing with everything you need to know for the NCLEX in the very straightforward way. If you take these buzzwords, if you write them down, I promise you, when you go and do a cardiology question, you say, oh, Dr. NCLEX said that. Are you done with the pediatrics? She said, no, I need to learn more. As she walked through the halls of the pediatric unit when she finished, she said, oh, there was a kid Very striking move. Rash on the face. That was going from up to down. And what is the problem? Patient has temperature over 5 days. Temperature is more than 5 days. He has bilateral conjunctivitis. And this rash is erythematous. And what is there? It's mucus. What? What is going? He has large node, adenopathy on his neck. There is large nodes on the lymph nodes are big on his neck. You look at the mouth, you have mucositis, right? Right. And then the kid pulled his tongue out and you have strawberry tongue. What do you think is going on with this patient? This is Kawasaki disease. And then the nurse said, I know this. What am I going to do with this patient? This patient needs high dose of aspirin. Then he will need immunoglobulin. This will help with the inflammation, right? But I got to worry about Ray's syndrome because of the aspirin. This is a viral problem. And mommy can watch this patient when they go home, but I got to worry about it. So far as the kid has fever, we have a problem. So high dose of aspirin and immunoglobulin. The kid will need echocardiogram. They will need EKG. We got to monitor the heart. But there's one thing when after we give the kid immunoglobulin that we have to worry about it. And that means no live vaccine. No live vaccine for 6 months. So, oh yeah, this is what I need. And if mommy go home, yes, you need to check for temperature. This is a full lecture of Kawasaki disease. Once again, this is all you need. Watch the video, write all the little things I've done. I've told you, put it down and look at it. I want you to know them. Know them. If you don't know anything about these little things, know these things I've told you. And the last patient they saw, the nurse saw, was very interesting. They said he had strep infection like 2 weeks ago. All of a sudden, the kid has joint problem. He has carditis, inflammation around the heart. There's some nodules on the skin. And then there's a rash that moves around, erythema marginatum. That is the key. But the most important aspect of it at all is this. The kid, it was like moving like a snake. What do you think is going on? And then you ask, oh, if he had strep infection, should I put him in isolation droplet? They said no, because this is not active infection. You don't need isolation for this patient. These are high yield. I'm giving you high yield fact. Trust me, high yield fact that you should know about this condition. This is rheumatic fever. And we have to be very vigilant. Prophylaxis, antibiotic, in order you don't get sick. If you have any infection of your heart, it's going to be a problem again. And the nurse said, 11 rooms, cardiac condition, NCLEX cardiac condition. We talk about tamponade, talk about chest tube, we talk about EKG, we talk about heart failure, how to manage chest pain, pulmonary edema. We went through pediatric cardiac condition, cardiac pharmacology. And he said, oh, each patient taught me something critical about NCLEX, and I've learned about it. Put this picture in your memory as you prepare to take the NCLEX. Make it memorable. You say, I know this patient, I know how to handle it. When they give you a case study, look at it and said, Kawasaki disease, T cramps. That's the buzzword. Tamponade, Berbick's triad, pericarditis, clicking sound, friction rub. Use the buzzwords. This is Adapt NCLEX. If this video help you, just smile and put down in the comment, cardiac, mastered. And if you need more, subscribe to Adapt NCLEX. And if you're not subscribed, subscribe for more content like this. Cardiac, I got this. Put it down in a hashtag, cardiac, I got it. Thank you for watching. Take care of yourself. Bye.